Hit the subscribe button or visit us at auau.auanet.org.
So the next subject on the agenda is manipulating the androgen axis, new agents in metastatic hormone-sensitive prostate cancer and castration-resistant prostate cancer. So certainly the recognition that the androgen receptor plays a role in castration-resistant disease was a major discovery that led to targeted agents with reasonable tolerability. And these are drugs that any urologist can utilize, and many do, but it's important to understand the side effects as well as the indications for all of these agents. No disclosures are pertinent. So androgen receptor pathway inhibitors are used at multiple steps now, including in castration-resistant disease, but they've been moved forward into the hormone-sensitive space and again have become a backbone of our treatment. This lecture has several objectives. We'll be talking about mechanisms of castration-resistant prostate cancer development, including androgen receptor enhancement, altered steroidogenesis. We'll discuss existing and new applications for these agents. We'll understand the mechanisms and some of the side effects of these androgen signaling inhibitors. And we'll talk a little bit at the end about side effects associated with androgen deprivation therapy and treatment. So to put this in context, this is a 72-year-old with metastatic castration-resistant prostate cancer. He had a history of biochemical recurrence following radiation for advanced prostate cancer. He was placed on androgen deprivation therapy once it was metastatic. And then 3 years later, he developed a rising PSA while on continuous therapy to 21. His testosterone was checked and found to be 19, and he had suppression, but he has new pelvic metastases noted on imaging with enlarged lymph nodes. So we'll talk about staging and options in the context of this patient. So it's a striking finding that over 70% of castration-resistant prostate cancer metastases and prostates exhibit amplified androgen receptor levels. And you can see there on the left staining in the prostate of a patient for androgen receptor with castration-resistant disease. And on the right, looking at autopsy samples in patients that have died from disease, over 73% of these samples demonstrate androgen receptor amplification. And it's important to realize that there are these ligand-dependent mechanisms and non-ligand-dependent mechanisms. So we're not going to be talking about the non-ligand-dependent mechanisms. These include co-activators and also alternate pathways, given there are not many agents that target these, but rather focusing more on these ligand-dependent mechanisms. In the center, you'll notice that androgen receptor amplification is an important aspect of an important mechanism. And it's been shown, presumably because there are increased levels of androgen receptor, they can bind more of the ligand that is present. In addition to amplification, to enhance the AR signal, the androgen receptor becomes more promiscuous, can actually bind adrenal androgens. That's shown in the upper right there. This is the target of Abiraterone, and we'll be talking more about that. On the left is looking at AR promiscuity, and again, the androgen receptor can develop mutations that allows it to utilize other steroids, including glucocorticoids and others that can lead to signaling. And then finally on the right is addressing the issue of androgen receptor variants. And these can auto-activate some of these splice variants. The most common one that we're familiar with is the ARV7 splice variant. So Abiraterone is an irreversible inhibitor of the hydroxylase and lyase activities of CYP17. This catalyzes the conversion of pregnenolone to DHEA. It's a much more potent than ketoconazole, which also has weak CYP17 inhibition. And it's been shown that there are a number of potential side effects associated with abiraterone, as one would expect. Since you're blocking these activities, you'll have increased aldosterone activity as well as cortisol, and that can lead to hypertension and low potassium. So patients are generally given steroids, prednisone, to help offset some of the side effects associated with this. Abiraterone was initially shown to prolong survival in the post-chemotherapy castration-resistant prostate cancer population. It's been pushed to pre-chemotherapy as well. And it not only improves survival, it improves radiologic, delaying radiologic development of metastases and other aspects as well. This is looking at some of the safety data from one of these trials done 6 to 7 years ago. And one thing to realize is that transaminases are elevated in these patients, so these need to be checked. In these patients, we also see the fluid retention, hypokalemia that we discussed. So to minimize the side effects of abiraterone, take on an empty stomach. Prednisone is given 5 milligrams BID in these patients. When you're initiating this agent, it's important to check liver function tests as well as the metabolic profile every 2 weeks after starting, and then monthly for the first 3 months, and then quarterly. And if patients develop the elevated liver function tests, hold until they normalize, and then restart the drug at a lower dose. It's also important to work with your primary prescribing physician for hypertension, fluid retention, aspects like this. And remember, drug interactions, Coumadin can increase the levels of other CYP drugs by altering its metabolism. Several years ago, there was the trial looking at application of abiraterone in patients with metastatic hormone-sensitive prostate cancer. We'll be talking a little bit more about that. So this drug has been gradually shifted forward in the disease course. Again, something that's important to be familiar with from a urologist standpoint. So which patients can we utilize abiraterone in? It's FDA approved for men with metastatic castration-resistant prostate cancer before and after chemotherapy. Also in metastatic hormone-sensitive prostate cancer in conjunction with androgen deprivation therapy. And it's off-label approved for metastatic castration-resistant, with M0 castration-resistant prostate cancer. Side effects: hypertension, hypokalemia, edema, also hyperglycemia that's related to the steroids. So one would want to be careful in applying this drug to individuals, for example, brittle diabetics, individuals with gastric ulcers, ongoing infections, things that, again, steroids can worsen. Also, patients with cardiac disease and obviously hepatic dysfunction or alcohol abuse, abiraterone may be the drug you want to steer away from. So this is just looking at sort of the landscape of oral androgen receptor pathway inhibitors. We see abiraterone at virtually all of these spaces, and we're going to be talking more about treatment intensification and the utilization of abiraterone and darolutamide that have now been approved in conjunction with ADT and docetaxel. So we'll talk about the other major group of androgen signaling inhibitors. The first one was enzalutamide. Again, this is a rationally designed androgen receptor inhibitor. It's often termed a second-generation non-steroidal anti-androgen, Casodex and bicalutamide being sort of the first generation. It has greatly increased efficacy for the androgen receptor. But it's important to realize it affects the androgen receptor at multiple points. It inhibits the binding of androgens to the androgen receptor. It also inhibits nuclear translocation of the androgen receptor and inhibits the association of androgen receptor with DNA as well. So again, blocking it at multiple points, hence the name androgen receptor signaling inhibitor. It is joined by apalutamide and darolutamide, which essentially have similar mechanisms of action. Enzalutamide was shown in both post and pre-docetaxel chemotherapy in patients in castration-resistant prostate cancer to have an improvement in overall survival. On the right there you see an improvement in radiographic progression-free survival as well. That was really quite profound with patients on this. Again, it was a 37% reduction in the risk of death on patients with enzalutamide. Common side effects include fatigue, hot flashes. These patients are also at increased risk of falls and hip fractures, so want to be careful in elderly patients with these drugs. As far as minimizing and managing the side effects of enzalutamide, there are a couple of things to think about. And again, advanced age, you can deal with these with dose reductions occasionally, but you also need to be aware that it can interact with other drugs. Gemfibrozil is a cholesterol drug, and need to be careful about utilizing enzalutamide in conjunction with this. If patients do have profound fatigue, and again, this is a common side effect, want to consider dose reductions or switching to abiraterone. Also, be careful with antidepressants such as bupropion, which can lower the seizure threshold, and using dose holds can help these patients prior to restarting with a reduced dose if they're experiencing some of these side effects. But remember, the half-life of enzalutamide is quite long at 8 to 9 days. So which patients would we want to utilize these drugs in? It's FDA approved for patients with metastatic castration-resistant prostate cancer before and after chemotherapy, also for non-metastatic CRPC and metastatic hormone-sensitive prostate cancer. Talked about side effects, profound fatigue, hypertension, constipation, rarely seizures, and it can cause some other CNS effects. So patients with a history of seizures, strokes, and falls would be considered a poor candidates. Patients who already have significant fatigue, and also being more careful in the elderly population for patients being placed on these agents. Let's spend just a moment talking about apalutamide, which has a very similar mechanism of action, a similar side effect profile in castration-resistant prostate cancer, although in the trials that were done, hypothyroidism was something that was also seen with apalutamide, as well as rashes. Darolutamide has a similar mechanism of action. There may be less penetration of the blood-brain barrier, which potentially could decrease some of these CNS effects that are seen with enzalutamide. We'll be talking in the next lecture or two about sequencing, but generally there's limited data to really guide between choosing these diseases. Obviously, looking at the patient, directing an appropriate drug is important. In the CARDS trial, they looked at sequencing abiraterone and then following with enzalutamide. There was a slight improvement in PSA progression in these patients. They were unable to comment on survival. However, in patients that got enzalutamide first, in abiraterone second, there was minimal change in PSA progression. But in this modern era, given a number of the other drugs that we have available, it's probably reasonable to, rather than sequence these androgen receptor pathway inhibitors, go to a different mechanism. There are unique situations that we want to be cognizant of, and we'll be talking again more about these, but certainly patients that have significant visceral disease or symptoms or very rapid disease progression, may want to go straight to docetaxel or carboplatin for aggressive variants, etoposide cisplatin for neuroendocrine or small cell, which rarely occurs, but it can. And always there are financial toxicity. We heard about this a little bit in our first lecture in these patients that may help direct the use of these drugs as well. So this is, again, summarizing our second generation oral androgen receptor pathway inhibitors. It's important to know how to apply these agents and where to apply them. And again, urologists are more likely to be involved in their application in metastatic hormone-sensitive prostate cancer and M0 CRPC. So let's spend a couple of minutes here discussing some of the adverse events with androgen deprivation therapy. And certainly quality of life is very important for these patients that are being placed on these drugs. Hot flashes are common, and we can use drugs such as venlafaxine and gabapentin to help minimize some of these effects. Osteoporosis and fracture risk is another aspect about this. Also, fatigue is common. One way to abrogate this is with exercise. Metabolic syndrome, many of us are aware, the weight gain really bothers a lot of these patients and may be a significant issue with regard to quality of life. Erectile dysfunction. We'll talk a little bit about cardiovascular and thromboembolic disease. So when one looks at androgen deprivation therapy and cardiovascular risk, it was back in 2010 that the FDA actually realized this connection and added new safety information to GnRH agonists warning of the increased risk of diabetes and certain cardiovascular disease issues like heart attack, sudden cardiac death, and stroke. It's important to realize, however, that some of these randomized controlled trials aren't necessarily powered to look at many of the cardiovascular risk aspects due to selection bias and also crossover from the control group. But when we look at meta-analyses of observational studies, there have been associations between ADT and greater cardiovascular events. They're consistent for GnRH agonists and cardiovascular events, and somewhat mixed associations with regard to antagonists. There are, with regard to ADT-associated cardiovascular morbidity, there was a study, HERO, in which they did look at some of these cardiovascular risks, and they found that there were increased risks of major cardiac events with leuprolide compared to relugolix in that study. It was 6.2 versus 2.9%. But when you look at some of the pooled data with these randomized controlled trials, there's really minimal difference in the cardiovascular risk profiles with these two different classes. So I think most people would feel like they're fairly comparable in this modern era. PRONOUNCE was another trial that focused on assessing some of the cardiovascular safety of these drugs, and it largely showed no difference in major cardiac events between these two classes of androgen deprivation therapy. So I think many people in the field feel like that they're fairly equivalent. As far as how we should assess these patients, it's important to realize that many patients when we initiate androgen deprivation therapy, they don't necessarily get a comprehensive assessment. And you can see there that in veterans, about 30% weren't assessed in this fashion. So it's important when we start these drugs that we consider looking at things such as blood pressure, lipids, blood glucose, and also screening and intervention to prevent diabetes in these patients. So I'll end by just mentioning the PATCH trial. And in the past, using estrogens in patients with advanced prostate cancer was associated with a lot of cardiovascular morbidity. But this is actually a trial looking at transdermal estradiol for androgen suppression in prostate cancer. Again, when it's given topically, you don't get the metabolites passing through the liver that can cause some of the cardiovascular issues. So one advantage about this approach is that hot flushes are significantly reduced in patients that are placed on these patches. There's rarely some skin toxicity. Obviously, there can be there is equivalent castration rates in these patients, and the risks of cardiovascular events were not different between the LHRH versus the estrogen patches. So these appear to be similar to the LHRH agonists in cardiovascular mortality and efficiency. The one downside of this drug is that it does have significant gynecomastia, which can obviously be problematic for the patient. So as far as our take-home points, the combination of androgen deprivation therapy and these signaling inhibitors and docetaxel, this triplet therapy, is a new standard of care in patients with hormone-sensitive prostate cancer. We'll be hearing more about that. Enzalutamide, apalutamide, and darolutamide are androgen receptor signaling inhibitors. Again, these are preferred in patients who can't really tolerate the systemic steroids, the brittle diabetics, and others that can't really go on Abiraterone. Abiraterone, conversely, is an androgen synthesis inhibitor, CYP17, and this may be slightly better in patients that have fatigue, seizure history, or on Coumadin. But again, it's important in these patients to monitor for side effects in patients receiving androgen deprivation. We'll be talking a little bit about bone health in one of our lectures coming up. And as far as cardiovascular issues, prevention is critical as well. So I'll stop there and introduce the next speaker. Thank you all.